This program is brought to you by Emory University.
Good morning. This morning we have Brad Leshnower, assistant professor in cardiac surgery. Brad did his medical school at UT Southwestern and then did training both at University of Pennsylvania and then at Emory. And he'll be talking today about management of aortic dissection.
Thank you. So we're going to focus on acute type B dissection only. Although it seems like you could cover type Bs pretty quickly, you can delve into it, slice it up, as I'll give you a flavor, and it can get complicated and detailed and quick. All right, so some brief numbers. Worldwide, overall aortic dissection, type A or type B, it's roughly about 30 cases in 1 million people per year. For our purposes in Atlanta, I'd say system-wide, we see about 50 type A's a year, and we're seeing more type B's, but 20, 25 true, like new acute type B's. So 2/3 type A, 1/3 type B is the standard classic numbers. And then drilling down into the acute B's, 30% roughly are complicated, 70% are uncomplicated. And that varies between 20 to 30%, 70 to 80%. Just a quick review, there's two classifications we use for aortic dissections. The Stanford is the easiest. Basically, anything proximal to the left subclavian is considered a type A. Anything distal is a type B. Dr. DeBakey went even more detailed and called a DeBakey 1 a dissection that involves the entire aorta. A type 2, which are pretty rare, involves only the ascending aorta. Then he took type 3 as the dissections that extend distal to the left subclavian, and he broke those up. 3A involves only that going to the diaphragm, or you could really even say functionally anything going down, even if it goes below the diaphragm, but stops above the celiac. And then 3B involves that abdominal aorta with the abdominal aortic branches, the visceral segments. So 3A and 3B kind of look like this. Definitions, briefly. Acute dissections, this is the standard thing that we think of. Less than 2 weeks, subacute is 2 weeks to 2 months, and chronic is more than 2 months. The International Registry of Aortic Dissection, or IRAD, has gone a little further, and this is starting to be used. A hyperacute within 24 hours, acute is 2 to 7 days, subacute and chronic are greater than 30 days. I think for type A's, this doesn't have that much applicability other than to give somebody a prognosis should they choose not to have surgery in an acute dissection. For type B's, it does carry some more prognosis with regards to treatment if you were going to stent them. They have a better ability in the acute phase due to the pliability of the dissection flap, probably to remodel them best within the first 7 to 14 days, and that decreases as you get out. But it does have survival prognoses when they looked at all these dissections. And basically what it's saying is, as you survive your dissection after 24 hours, your chances of surviving go up, which is not a big surprise. So drilling down on type B, when you get a type B dissection, you need to ask two questions. Is it acute or chronic? And is it complicated or uncomplicated? The acute or chronic thing, generally you should be able to determine from their history. History is very important in this disease. And when I get a lot of calls from ERs saying, oh my God, this guy has a dissection, but they were scanned for some other incidental reason. They don't have the classic story of acute onset of severe chest or back pain. Then in my mind, there's a couple things you can look for on the CT, which can lead you and guide you to say whether it's acute or chronic. Then you want to know if it's complicated or uncomplicated. And again, for the purposes of today, I'm going to stick on just acutes because that is becoming, especially the acute complicated is really where the current controversy in the field exists. And the FDA, just so everyone knows, they decided to approve endovascular therapy for all subgroups, even though the only data that currently exists for any of the subgroups is acute complicated, which was a big surprise. So let's go over complicated versus uncomplicated. A true complicated, hard signs of a complication are either rupture or malperfusion. Now, when we talk about rupture, there are probably patients that rupture and die that we never see, and we don't really know what the denominator is. So what we're really talking about is contained or impending rupture, and that is marked by periaortic hematoma, a very irregular aortic contour, and pleural effusions. Now, a lot of these patients have tiny pleural effusions, but I'll show you. This is what gets to impending rupture and a big effusion, which I'll show you. So this little dot of contrast is what we're talking about for the irregular contour. That is a very unstable aorta combined with that hematoma. This is a very unpredictable situation that could rupture any second. And surprisingly, these patients will come in totally stable. But I've had patients come in like this. They've been totally stable. We got them to the OR, and with induction of anesthesia, before we could even put a needle or wire into them, they died. So it's very unstable. This is a pleural effusion that makes you worry. And it's not subtle, obviously. And actually, you can see here, this cutoff is not lung here, but rather the actual red cells by gravity falling down and collecting in the chest. So that is obvious signs of rupture. Now, malperfusion is a clinical diagnosis, but there's also radiographic findings. And malperfusion, a patient can have a pulse in a leg and still have malperfusion. If it is because there's a spectrum, they can have malperfusion but not be ischemic, and we've seen that a lot. Compared to the other side, their pulse is thready, it's not quite right. They can have claudication. They can have acute kidney injury with normal-sized kidneys. Frequently, I will see CT scans, someone who has normal-sized kidneys, normal-looking kidneys, and they have received 1 contrast load, and they get there and their creatinine's 2. And everyone chalks it up, well, they just had a creatinine load. No, I don't buy that. I think that is low flow to the kidneys, because most of us with normal kidneys, our creatinine won't budge. Radiographic signs you will see here. So there's a kidney out. That's radiographic malperfusion. Okay, hard sign to stent. This is a softer sign, but a worrisome sign. This is the true lumen here. It's always the smaller one. And that is massive true lumen compression. When you get down into the abdomen and you see that sign, that is a very ominous sign that you are likely going to have malperfusion in this patient. And sometimes it can be very difficult to diagnose. There are mechanisms to the malperfusion, too. So dynamic malperfusion refers to actually the floppy flap, and I'll show you some IVUS examples coming up. In an acute dissection, that this flap can move over and actually obstruct an orifice to a branch vessel. The dynamic malperfusions are actually the ones that really respond well to a stent graft, even proximally. If you stent open the descending thoracic aorta, a dynamic malperfusion in the abdomen will usually resolve. Static malperfusion refers to a clot, or more commonly, when the flap dissects into a branch vessel and false lumen pressure is higher than true lumen pressure, usually, and compresses that vessel. These type of static malperfusions do not typically respond to just a stent graft proximally in the descending thoracic aorta, and will usually require branch vessel stenting to relieve that static malperfusion. So it's important to understand those 2 different types in the pathophysiology. So I have another category of complicated here, which is morphologic evolution. So if a patient comes in, they don't have rupture, they clinically don't have malperfusion, radiographically have malperfusion, they are super hypertensive, and they're usually in the hospital with us about a week. And it usually takes 4 blood pressure medications, at least, to control their blood pressure. And during that time, I will repeat their scans at least once, maybe twice. And if I see any morphologic change in the false lumen or rapid expansion in the diameter, that, to me, is a bad predictor, and we will stent them. And then there's the uncomplicated patients. That's everyone else. And I'll touch on this. This is where the controversy in the field is uncomplicated dissections now are being broken into high risk and non-high risk, and we'll get to that in a second. So just a little bit of data. Type Bs are considered the more benign, but the fact is they're very unpredictable compared to a type A. We all know what to do with a type A. Go to the operating room. And we all know now what to do with complicated type B. That needs to be stented. But the IRAD database, and this is old, but it still rings true. They looked at all patients with type Bs and the mortality, no matter what the treatment was. And it's 25% at 3 years. Now that we're going to drill down to that in a second. And just to sort of highlight the better treatment and results with stenting, you can look at open surgery for complicated type B, which is pretty rare. I've done one. A handful of my partners have done these over the years. They don't do well. Their overall in-hospital mortality, if you do open surgery for a type B, is almost 30%. And if they're ruptured, they're even worse. A malperfusion does better. The surgery, if you have to do surgery earlier, if their mortality is higher, that's just a sicker patient versus a less sicker patient, and they stay in the house for a month. This is a picture, it's a little bit hard to tell because we don't see these a lot, of a ruptured type B that we operated on. Open, this is the head up here, here's the feet. And you can see this aorta that has just completely, this is a rupture case, so it is a contained rupture actually into the right chest. You can barely tell anatomy here. And this is then the repair, a big long tube graft all the way down to the diaphragm. Okay, so we stayed in the chest in this one. So what are the principles of stenting these type Bs? Number one, you have to eliminate antegrade flow, all antegrade flow into the false lumen by covering the primary tear. That's number one. And we are now stenting all the way down from left subclavian to celiac, typically, for remodeling purposes. What you're doing there is trying to expand the true lumen, divert all the flow into the true lumen, restore adequate inflow to the distal aorta. If you do that, they will do much better, and you will have success. I don't have the films for this. I recently had a tough one because of an angulated arch. So in the young people, as you may know, their aortic arches are very angulated, and often these dissection, their great vessels can be very close together, and the dissection flap can start really in the ostium frequently of the left subclavian, requiring coverage, which we do. And I had a lady come in who, because of her angulated arch, I could not get the graft to lay down right, and she had persistent false lumen filling of her proximal descending thoracic aorta, and I said, well, we'll see if sometimes these still thrombose if they have no outflow. But I had done a good job distally of eliminating the false lumen, and I had created a blind sac. So she left the hospital, and 2 weeks later came back with excruciating pain. Right here, she had filling, and this area had grown 1 centimeter in 3 weeks. She was in excruciating back pain, and she had essentially had a 5-centimeter aneurysm here. And so we took her and actually did an ascending total arch, sewed to the stent graft, big operation, and she felt instantly better because we had shut off this flow into this blind sac that was really causing rapid expansion and pain. So again, the technical goal is to eliminate all antegrade flow into the false lumen. Remodeling the aorta is really what you're doing. You're relocating the dissection flap back to its native position against the false lumen wall. Again, expand the true lumen, reduce the size of the false lumen, and ideally thrombose or even obliterate the false lumen. This is what an IVUS looks like in a type B. So we're coming around the arch, and you're about to see a flap here. There's the primary intimal tear. And as you get further down here, it will look pretty floppy. And this is even, we have a stiff wire in here, so it tents open the flap. Often these flaps are just minuscule initially when you put the wire in. But it's pretty easy to see. In the abdomen here, it's starting to get smaller. IVUS is mandatory for dissection stenting. It confirms where you are. I've operated on somebody who put a stent graft that crossed over from the true and false lumen because he didn't use IVUS. You can do a whole case with IVUS with no contrast, identifying your things and marking it. So it is really a mandatory tool. It's a great tool. It's easy to use. You know, you guys use it for coronaries. It's even easier in a big aortic vessel. When you have a type B with malperfusion, your algorithm, again, cover the primary tear and then go distally and evaluate with angiograms, IVUSs, measuring femoral pressures to identify if you have persistent malperfusion. If you do, which is, you know, not unusual, the key steps are to extend your stent graft. When we started this, people just put a short stent graft up at the top. But now we extend routinely all the way down to the celiac. And then if we still have, for instance, static malperfusion in any of the branch vessels, they get stented. And if that doesn't work, they may get a bypass, such as a fem-fem bypass or an ax-fem bypass. But you have to relieve all the malperfusion here. Rupture, we are starting to see more and more of these, actually. And this angio shows it. We rarely actually see a blush like this. Most of the time, you see you just see a normal aorta because they've leaked blood, and for some reason the aorta seals, at least temporarily, and you do not see extravasation of contrast like you do here. The goal with rupture is you don't really know, in this setting you do, but you don't know often where that site of rupture is of the false lumen. So you have to cover as much as you can and hope that gets it. That means covering the left subclavian all the way down to the celiac. All right, so a couple of papers of results. Now, this is the first paper from Penn where they really sort of brought to light that this should be the new paradigm for complicated type Bs, is stenting. Their indications for TEVAR, 50% were rupture, almost 50% were malperfusion. They did a number of distal stenting, 35 patients. This is now, you know, almost 13 years old. They had one mortality in 30 days, two in a year. They had one stroke. They had some transient paraparesis and permanent paraplegia, renal failure. But this was the paper that was sort of the first on the map, at least in this country, to say this is how we should treat patients with stent grafting for complicated Bs. There's a number of other papers that have come out. Here is our recent series in press that because we see quite a number of type Bs here. So from 2012 to 2015, we treated 51 patients. We had 2 mortalities. These were ruptures that ruptured in the abdomen. So you can stent all the way to the celiac, but they can still rupture in the abdomen. You sort of have no control. There, we had an additional patient die, I'm not sure why, for a total of 3 in 1 year for a mortality rate of 5.8%. We had 2 strokes. We had 3 patients who developed delayed paraparesis. So when you stent from the left subclavian to the celiac, the longer the coverage that it is, the higher risk that you get spinal cord ischemia. We wake these patients up and extubate them on the table. However, they then go to the ICU and you have to be extremely vigilant. Even in ruptures, I keep the blood pressure systolics of 160 to 200, and they get neurochecks every hour. The first time that neurocheck is abnormal, they get a lumbar drain. So all 3 of these were delayed paraparesis within 24 hours, where their blood pressure inadvertently was lowered, or they just developed it despite a good blood pressure, and we got all of them back with augmenting their blood pressure and lumbar drainage. We had no permanent paraplegia and no renal failure. Now, with any endovascular therapy compared to an open operation, you're going to have reinterventions. In our series, we had 5 endovascular reinterventions. Some of these were left subclavian plugs. A couple were stent graft extensions. And we had 6 people who had concomitant ascending aortic disease or had separate type A's that were not related to the stent graft. So, I mean, these patients all have abnormal aortas, all of them. And either they have had aneurysms that have dissected and they have ascendings that need to be fixed, or I've had 2 or 3 of these a year or 2 out after they had their type B stented, where they came in with a type A, and they were not related to the stent graft. Now, I will tell you that one of the risks of this operation, especially as you put a stent graft more proximally in the arch, is causing a retrograde type A dissection. So you have to be vigilant about that. So we looked at outcomes, and then our spin on this was we wanted to look at remodeling. So here's an example of a stent that goes from left subclavian all the way to the celiac. We then slice the aorta in 5 different segments to look at how the aorta is remodeled with the stent graft proximally. And here's an example. So this is the acute dissection before a stent graft, and this is what it'll look like afterwards. You still have a fair amount of false lumen. This is before they go home, they get a scan. This is at 1 month. You can see the false lumen now is virtually thrombosed, okay, compared. There's no contrast or very minimal here. At 1 year, false lumen totally obliterated. That's what you want to see. They are in good shape for life along the length of the stent in their chest. They should not develop an aneurysm because they don't have any residual dissection. They have 1 lumen that is bolstered by this stent graft. So we looked at how you remodel them, how the false lumen, the true lumen expands, the false lumen shrinks, and thrombosis by segment. So after they get stented before they leave, you can see that the majority, well, I should say, so the proximal and mid DTA, the descending, is stented. That's the stented segment. And some of them down to the hiatus. Because the latter half of our series is when we started getting aggressive and stenting more and longer to the celiac. So a lot of them still have patent false lumens, and in the abdomen, the false lumen remains patent. And partial thrombosis and complete thrombosis along the length of the stent, these 2 top ones, are starting to get fairly high numbers. This is a year out, and you can see that the majority of the stented segment has complete obliteration or complete thrombosis. But the abdomen again stays patent. When you look at the size of the aorta, okay, because that's what we're treating in the follow-up. If you stent someone, even if the false lumen is thrombosed, but the aorta keeps growing, you have a problem. Okay, you have an aneurysm. You're treating it like an aneurysm. So these top 2 segments, again, are the proximal and mid-descending thoracic aorta, and their aortic diameter has stabilized. And if you broke it down, what you would see is that the true lumen expanded and the false lumen either thrombosed and was obliterated or shrunk. However, in the abdomen, the aorta grew a little bit, okay? Statistically significant. So, our message in this paper, this is another series where we can say, for these sick patients with high mortality, stenting is safe, low morbidity and low mortality, and it shows excellent remodeling outcomes. We've expanded the true lumen, we've obliterated the false lumen in the majority of the patients along the length of the stent. We've induced partial or complete thrombosis of the false lumen in those that still have a residual false lumen, and we've stabilized aortic diameter along the length of the stent, but these patients require lifelong surveillance for that abdominal aorta, which remains dissected, but they come in every year, and I say, it looks good, everything has blood flow. They rarely develop malperfusion in the chronic phase, and you're just watching that abdominal aorta to make sure it doesn't grow big into an aneurysm. Here's a case, and then we're going to move on to the uncomplicateds. This was a 51-year-old who came initially to an outside hospital, and then over actually to Midtown with acute back pain and abdominal pain. Classic story. CT scan, acute type B. Initially, when he was seen, he was pain-free, had palpable femoral pulses. I went over there and examined him, and his exam had changed compared to the previous exams by my partners. He was now somnolent. His abdomen was benign, but I could not feel pulses, and he was anuric. His creatinine was elevated, his platelets were down, and he had a lactate of 4. This is his CT scan. So you can see a very compressed true lumen here. And I had to patch together 2 scans here, so it's a little bit bad. But you can see that this true lumen is completely compressed above the renals, okay? I will also point out to you, look at the kidneys here. They're normal size, and they appear to be getting blood flow. They light up. But he's anuric with a creatinine of 2.5. So in my mind, he's got an acute TBAD 3B dissection. He's got renal and iliofemoral malperfusion. I can't feel his pulses. Massive thoracic true lumen compression. Acute kidney injury. He has a distal inflow problem to the aorta below the diaphragm. And we can fix this with a stent graft. So we take him to the hybrid OR. You always cut down. In this situation, we couldn't feel pulses in either leg. But if you have a cold leg, that's the true lumen side, because the false lumen is usually getting blood flow. So we cut down on the right femoral. We're now doing a lot of these totally percutaneous. Put a sheath in the left. Measured pressure. So we set it up just like the cath lab. So in the right radial, which is always your true lumen, remember, and if you have trouble getting into the false lumen, you can put a catheter up the right radial. We have a blood pressure of 121/58, mean of 77, and this is not a bad pressure. This is real. You have a tissue pressure of about 40, non-pulsatile, in both, really. So we get all our wires and catheters up, do an IVUS, put a stent graft in. When we land these, especially in the arch, we'd lower the blood pressure to less than 90. And after our first stent graft, our femoral artery pressure increased now, 84/51. So it was better, but it wasn't normal. We then did a second stent graft, extended to the celiac, did not shoot a picture. Remember, this guy's in renal failure. And now we have essentially normal blood pressures in the right radial and the right femoral. It's pulsatile, so equal, okay? We shot an aortogram just to confirm that all the visceral vessels and organs were reperfused, and they were. We had resolved the malperfusion. And as soon as we lay down the first stent, we tell the anesthesiologist, increase the blood pressure. There is nothing worse than having a paraplegic patient. I hope you never have one. And this is what we're worried about, even in ruptures. So increase systolic to, actually I say greater than 160, go on pressors if you have to. Immediately in this patient, we start seeing urine in the Foley. Extubate him. He's not moving his legs. Now, was this real? Was this because the guy had some anesthesia? You don't know, but you cannot take the chance. Fortunately, with our cardiac anesthesiologists here, they're excellent. They can put in lumbar drains, lickety-split. So they don't even leave the OR. Stat lumbar drain in the OR. He started moving his legs an hour later in the ICU. We drained him for 3 days, kept his mean pressures sky high, which is not that hard, by the way, in these hypertensive patients who, as I told you, need 4 or 5 medications by the time they leave the hospital. He left on day 11, normal neuroexam walking, creatinine 1.8, palpable pulse in his feet. Here's his 1-month post-op CT. That's the stent graft. You see false lumen, complete thrombosis, and that will shrink up over time to where it's just the stent that you see. He had a good remodeling result here. Stent graft ends there, and you see no residual dissection because his ended at the renals anyways. So this was a good case of a complicated B. So this is a dated document now, but it still rings true. So this is from the STS experts on thoracic aortic stent grafting, who said, this is Craig Miller from Stanford, emergency stent grafting with life-threatening complication of acute type B dissections may save lives and could well become the most clinically valuable application of thoracic aortic stent grafting in the future. Now this is what we need to focus on, because this is the current controversy. In patients with uncomplicated acute Bs, medical management constitutes a benchmark that will be difficult to surpass or even match by endovascular stent graft treatment. So this is where the controversy lies now. There is no doubt stenting for complicated Bs is the way to go. It's the optimal therapy. But what about the uncomplicateds? What's better? Should we stent these patients? Should we medically manage them? All right, let's look at the data. So OMT stands for optimal medical therapy. What's the data? Well, we have to look at natural history data. As far as data on TEVAR for uncomplicated type B, there's minimal. Okay, there's 2 trials. ADSORB, which I'll go over, is an acute trial, and the INSTEAD trial is a chronic trial that is flawed, has some valuable things, but is not, it has some pertinent points for uncomplicated, but we're not going to get into that today. I can answer questions about it. Well, this is an interdisciplinary expert consensus document published in JACC in 2013. And it says medical management for in-hospital medical management leads to an in-hospital mortality of 6%. That's pretty good for an uncomplicated B. Long-term survival gets a little worse, all right? We said that IRAD data was 24%. 1 in 4 are dead in 3 years, all comers with type Bs. That's old data. This is a little bit newer. So this paper came out of the MGH in 2015, very important paper. They looked at all their acute uncomplicated type Bs from 1999 to 2011, so a modern era, and they had almost 300 patients uncomplicated that were treated with medical therapy. Mean follow-up of 4 years, 58% failed medical therapy, all right? So they got them out of the hospital with good results, just like that previous document showed. Short-term mortality, excellent. But look what happens long-term. So 58% failed medical therapy, 38% of them died. That has to be assumed to be aortic rupture. One of the flawed things about these studies, and even our own, is it's very difficult when these patients die to figure out why they died. Did they die of an aortic problem? Because that's really what we want to know. 29% of the patients required an intervention. Okay, and here's the telling stat. So if you look at these type Bs, 41% of them only 41% had an intervention-free survival at 6 years. So only 41% were either alive or did not have an intervention at 6 years. That's bad. Now, when they intervened, those who intervened, their survival curve improved. Those who continued on the medical management course had a significantly lower survival, and those survival curves diverge at 2 years. I won't get into the significance of that now, but when you talk about stenting for aortic and remodeling the aorta, really it takes 2 years to see any survival benefit. You will see radiographic benefit pretty quickly, but in terms of preventing aneurysms and preventing rupture, it's starting to come out that 2 years is a significant time point. So we looked at our data and we said, all right, let's look at all the type Bs at this institution. And what is the impact of the various therapies? We just presented this at the STS in January. So we wanted to review our long-term experience with all type Bs at this institution. We wanted to characterize, just like the MGH study, the natural history of uncomplicated Bs with medical therapy alone, and then figure out what's the impact of TEVAR in the acute versus chronic phase on long-term survival. So in a 16-year period, we got 400 patients with what we called de novo type Bs. And what I mean by that, these were not residual type As where we fixed the proximal and we're left with dealing with the chronically distal aorta. Because, I don't know, those patients may act differently. Their primary tear theoretically has been resected. Does that matter? We're trying to figure that out. But these were only de novo type Bs. So here's our things, how we broke things down. Of the 400, almost 400 patients, about 20%, 80 of them, got stented within 2 weeks of presentation. So these were complicated patients that got stented. The uncomplicated, about 80%, 318, all received medical management. And what happened to these patients over this period? Well, about 46% needed an intervention, all right? Almost 60 went to open surgery. In the more recent stent graft era, the last 5 years, we started to stent more of the chronics, but we still had a chunk of patients that remained on medical therapy. We'll skip through these demographics. It's a pretty, between complicated and uncomplicated, it's a pretty evenly matched cohort. Little bit, these differences are in hypertension, diabetes, beta blockers, etc. How did they present in the chronic phase that required them to have either open surgery or a stent graft? Well, most of them were for aneurysm formation. The false lumen is weak and it will develop into an aneurysm. So most of them were done for aneurysm. Now, this is an important slide here. For the acutes, and these were complicated patients, so they are by definition sicker. They have malperfusion or they're ruptured. Their in-house mortality with stent graft therapy was 5%, which interestingly enough was the exact same as if you medically managed the uncomplicated, which were a lower risk group of patients with medicine. So it's safe, okay? That tells me it's safe because stenting did not increase mortality in a much higher risk group. Of those who underwent interventions, you can see that in-hospital mortality was highest in those who had open surgery. Remember, these are chronics, but nevertheless, and that's no surprise, open surgery is definitely going to be a higher risk adventure than stenting in hospital, all right? And the stroke rate is definitely higher in endovascular interventions, even in the acute phase, okay? It's higher. So the trade-off is you have a higher risk of stroke by getting stented up front. These are showing reinterventions. I'll skip this, but basically, as I mentioned before, any endovascular intervention compared to open surgery, there are going to be a higher number of reinterventions. Why? You're cutting out the disease segment with open surgery, and it's still there when you stent graft it, so it's pretty simple. So these are the key figures I want to harp on here. So this is a survival curve looking at complicated versus uncomplicated in our series. And what you can see here is that even though the patients who were sicker, they were complicated, they have a higher 10-year survival compared to the uncomplicateds. And what was the difference? They were stented up front, okay? It did not reach statistical significance because we don't have enough patients out quite yet to 10 years, but I'm pretty confident as we accrue more data that will become statistically significant. This is a busy slide. It's looking at all cohorts who got treated with either a stent graft acutely, open, or stent graft chronically, or medical therapy. Again, the complicated, sicker patients who got stented up front still have the highest survival. Looking at open versus stent graft versus medical therapy, well, yes, medical therapy technically is better than if you have to get intervened upon, but that makes sense. You've selected yourself as a higher risk by developing an aneurysm if you had to get a stent or open surgery in the chronic phase. This is something to bear notice, is that the open surgical candidates did better long term than if you got a stent. And finally, this is the last figure I want to look at. This is our intervention-free survival, just like the Mass General one. Theirs was, I think I said 40%. Ours is even worse. So if you look at only uncomplicated patients who showed up within the Emory Health System, were treated with medicine first, how many of them were still alive or did not require an intervention at 10 years? Only 30%. So this is pretty damning evidence that medical therapy, while it does provide good short-term outcomes, long-term, it's not good. So our conclusions from this: complicated type Bs, who are the sicker patients, undergoing TEVAR have excellent early and long-term outcomes. The natural history of uncomplicated type Bs here within the Emory system are short-term in-house mortality, excellent, 5%. 46% required surgery or a stent in the chronic phase. And again, our intervention-free survival was 50% at 5 years and 30% at 10 years. So the question then is, does putting a stent graft in up front give you a survival advantage? And should we be doing this not only for complicated, but uncomplicated type Bs? Is there a role for prophylactic stent grafting in an uncomplicated type B? This is the one trial that currently exists, ADSORB. What this did was randomized prospective trial in Europe of optimal medical therapy, they called it best medical therapy, BMT, versus best medical therapy plus a stent graft. From 2008 to 2010, treatment were within 14 days of onset of symptoms. Very low enrolling small trial. 61 patients, a few crossovers. Here's basically what you had to do to get into the trial from an anatomic standpoint. You'd have a proximal landing zone of 2 centimeters, which frequently you don't have. So this was, very difficult to enroll in. Their composite primary endpoint was was a composite of remodeling, indices, and rupture, because they knew that remodeling I should say that uncomplicated has a very good short-term outcome, as we've discussed with just medical therapy. So, incomplete or no false lumen thrombosis along the length of the stent graft. An increase, did the aorta grow? Did the aorta rupture, basically? So, remodeling, did it grow? They had 14 patients fall out because they had inadequate or no imaging. To cut to the chase here, so they only had 23 patients at their 1-year follow-up in each group. It showed that stenting, this is the incomplete thrombosis. So the way to think of it is that 83% of the stent graft group provided remodeling. Only 17% did not. And they probably had antegrade filling. They probably did not have a technically successful procedure. There was no aortic rupture in either group. And there was really minimal mortality. And really very minimal patients grew more than 5 millimeters in a year, which I could see all this. I follow these patients in my clinic. They grow, but not that quickly. Here are the remodeling things, and what this shows is that the true lumen expanded in the TEVAR group from 22 to 32 millimeters, statistically significant. Stayed the same with just medical therapy. The false lumen reduced or shrunk in size with the stent graft, 24 millimeters to 18, and it actually grew slightly in the medical therapy. And then aortic size was similar. So they concluded the addition of stent graft increased the freedom from the composite primary endpoint. TEVAR is more effective in promoting remodeling, and that we need a larger randomized controlled trial to determine the benefits. This is too small of a trial, and their endpoints are too quick. Again, you're not going to see a benefit when you're looking at the uncomplicated patients between stenting and medical therapy until at least 2 years, as shown in that slide from the MGH study. So, the risk for stenting an uncomplicated B, higher morbidity and mortality around the time of the procedure. In our hands, mainly it was stroke, okay? You do have potential adverse downstream false lumen remodeling, such as the case I told you where I could not shut off antegrade flow and actually created worse of a problem. You could create worse of a problem by stenting the uncomplicateds, okay? And the cost of the stent graft. The benefit, however, as I'm trying to show, is that long-term survival is terrible with medical therapy in type Bs, and by stenting and remodeling the aorta up front, you can prevent that aneurysmal degeneration in the thoracoabdominal aorta, specifically in the chest along the length of the stent. So, a couple of final questions. The real gold here is to look at and find out which patients have, predictors that say they're going to grow and develop an aneurysm, and which, because there will be some that don't even develop any aneurysms or any problems, and medical therapy would just be fine, but we can't figure that out. The data suggests that 20 to 40% will require surgery within 5 years. And so a couple of high-risk features, bad actors, as we should say, in uncomplicated Bs. This is an IRAD paper, which is very important. From 1996 to 2004, they looked at 300 uncomplicated Bs. However, they looked at pain, refractory back pain, or hypertension as a predictor. Did this matter? And of these 69 patients, they were managed, some medically, some with open surgery, some with endovascular therapy. So again, these were type Bs that did not present with rupture or malperfusion, but had refractory pain within this 300 patient group. So what is the significance of this hypertension and pain? When you look at all of the patients and they were treated with the 3 modalities, medical, open, or stent graft, if they had refractory hypertension or pain, their mortality rate in-house was 17% compared to 4% when they were truly uncomplicated and had no pain. When you take out the surgical or endovascular intervention and just said, okay, these patients that were treated with medicine only, if they had refractory hypertension and pain, their mortality rate was up to 35%. So, medical management in this group of refractory hypertension and pain, 2/3 of them, of the deaths that occurred, were due to aortic rupture. It was clearly, statistically, they had an odds ratio of 3.31, higher risk of in-hospital mortality. So intervening on this group of patients with refractory pain or hypertension matters. And finally, there's been a number of studies trying to identify those patients who are going to develop an aneurysm and get into trouble. And these are the results, basically radiographic predictors. We're also undertaking studies like this right now as well. But when they present, if they have an initial aortic diameter of force greater than or equal to 4 centimeters and a patent false lumen, that's predictive of enlargement. If they have a patent false lumen alone, that's been shown to be an independent risk factor for increasing aortic diameter. Partially thrombosed false lumen has been shown to be an independent predictor of mortality in type Bs. And finally, and by that meaning that the mortality is assumed to be an aortic rupture, and then a false lumen diameter greater than 22 millimeters in the proximal descending correlates with aneurysmal change in mortality. Here's what I use. If the patient comes in and they go into the uncomplicated route, if they have refractory hypertension and pain, I'm stenting them. If they have a false lumen greater than 22 millimeters or a total aortic diameter greater than 4 centimeters, they're getting stented. I don't judge things by the false lumen status, whether it's partially thrombosed. It rarely is, in my mind. In acute dissection, most of them have patent false lumens. I think that we are on the aggressive side here, admittedly, but when I talk to colleagues around the country, the field is moving towards stenting uncomplicated type Bs. There is supposedly in the works proposals for a prospective randomized trial, but it will be very difficult to conduct, mainly because people are already biased into stenting these people. A lot of people will argue there's really no such thing as an uncomplicated type B. So, in summary, we know that stenting the complicated Bs, optimal therapy. For acute complicated type Bs, very controversial. As I have pointed out, medical therapy provides excellent short-term outcomes, but poor long-term outcomes, mainly because a significant proportion of patients form aneurysms in the false lumen, and the overall rate of intervention-free survival is low. With stent graft, we stent the high-risk features. It's unclear. I mean, there are certain patients I will not stent that are uncomplicated. If they have bad anatomy, if they have other medical comorbidities, age plays a predictor. So we haven't worked this all out. Yes, a randomized controlled trial is needed, but I am pessimistic that that will ever be conducted in a true fashion. Thank you, and I'll take questions.
Thanks, Brad. Just to start us off, the issue around blood pressure management in the patient who has paraplegia, how do you manage the patient who presents acutely with paraplegia and a dissection before you do operative therapy? And then the second question I have is just a comment on the long-term follow-up of patients that we're seeing in our clinics who have the type Bs, that uncomplicated type Bs who are being managed medically. How do you follow them? What type of imaging do they need?
So paraplegia, as I said, is the most dismal complication. And for type Bs, I've had 3, I think, we're up to about 70 or 80 acutes that we've taken and stented. I have immediately stented all of them, and I have never gotten one back in terms of their legs. They live, but they're paraplegic. I've drained them afterwards. I'm thinking this is some sort of spinal cord malperfusion, and all I know is to reperfuse the spinal cord the best methods we can. Now, should we stent them a short segment? Should we stent them a long segment? I don't know, and I don't think anyone knows. Certainly, you're treating this problem with a modality that can cause the problem by covering the intercostals all the way down. But I've never gotten one back. For type A's that present with paraplegia, fortunately, this is also a rare event. I have taken those patients immediately to the operating room and gotten them on pump and replaced their ascending aorta, done as minimal operation as I can. And then I've had 2 of these, and both of them I've gotten back. They woke up, they were moving but not right, and I immediately put a lumbar drain in afterwards. So, and then the management is aggressive drainage, sometimes to an ICP less than 5. And there's risks to that, obviously. You can cause cerebellar hemorrhages. It is very challenging. And then getting their blood pressure up to try and increase the collateral circulation to the spinal cord through left subclavian, vertebrals, and hypogastrics. So that's number 1. How to follow the chronics. Our typical protocol is they get imaged quite a bit in the first year of an acute type B. 1, 3, 6, and 12. Sometimes we skip the 3 month. Then we go annually. We can generally, and unfortunately ultrasound is not sufficient, so they get a CT scan, and you can do it without contrast. Yes, you can do MRI, and that's fine. It just takes longer, and the images aren't as good. If a patient is clinically well perfused, you can get a non-con CT scan of their chest, abdomen, pelvis. All you're looking at is diameters, and you can get a pretty good size. If they get to a critical threshold then of whether they may need surgery, I may repeat the scan with contrast. But it's generally on a yearly basis. If you see growth, you might move it up to 6 months. That's my protocol.
Has anybody tried using partly covered stent and then partly uncovered stent? So in your inlet, you put a covered stent that has got covering on it, endografts, but then you have a bare stent after that.
Yeah,
let me to perfuse the intercostals.
Right. So do I have a picture of this stent in this later? I might. There is a. The answer is yes. I don't have it in this. There's a stent that Cook's making called and is sort of a specific dissection stent that will, you can have your proximal part is covered as long as you want. So you could put a short segment like you're stating, and then it has bare metal throughout. And we don't have access to that device yet. It's going to get approved, but I would use that. I would still probably use covered all the way down to the celiac, and then bare metal through the visceral segment of the aorta. The reason being is with bare metal, there's, as you know, it's not just one tear up top. So if you use bare metal throughout the mid-descending aorta all the way down, there will be intimal tears with blood flow going in and out of the true and false lumen that wouldn't be covered. But for distal aortic problems, yes, is the answer to your question. They're using bare metal throughout there. And we've had to do that for we've had some cases where, specifically in the mesenteric malperfusions, where you stent to the celiac and the pressure is so high in the false lumen that as soon as you leave the stent, the true lumen gets collapsed. And we've had to create our own bare metal stenting of that visceral segment. It's a problem, but yeah.
How long do you maintain that high pressure, greater than 160, in the outpatient settings?
I don't. So in the ICU, it's about 24 hours, and if they have a normal neuro exam, then we relax the blood pressure, and typically these patients are doing it on their own. We don't even have to give them pressors. And I will send them home hypertensive. I do. And then when I see them back at a month, I start gradually increasing the blood pressure. Because these people are used to that blood pressure anyways. But I have had an occasional patient where they've taken their blood pressure and they feel a little weak, like 2 weeks out. And I will call them back in and either image them, take them off all their blood pressure medicine. Sometimes I've admitted them and put them on pressors. And we've been able to get them back, but it is, it's a dicey situation, no doubt.
Thanks.
Brad. For those of us who've been watching this for a lot of years, that was fantastic.
Thank you.
I thought you had a question.
Rebecca.
Quickly, for these uncomplicated type Bs who you may be, monitoring and planning before they undergo surgery, can you comment on your cardiac risk stratification and what is necessary in these patients since they're probably high risk and have coronary disease?
So if they are in-house and they come in and they're uncomplicated, for instance, they just have high-risk features like I pointed out, I only get an echo. That's it. I do not cath these patients at all. And my experience actually is most of these patients that have isolated aortic disease, which is the majority of them, do not have concomitant coronary disease. When we look at our elective aneurysm, thoracic aortic repairs and replacements, et cetera, we cath all of them because we're going in their chest, but it is pretty rare that we have to do concomitant coronary bypass. So I typically get an echo, obviously EKG. If there's abnormalities from that, that's our screen, essentially. Then we go from there. We do get, but for instance, when we do operate on these open chronically, they all get caths just because, and frequently if they have concomitant coronary disease, I'll ask you guys to stent them because it makes our operation easier. We'll wait on them. We'll wait 6 months sometimes for the open, descending, and thoracos. We can do concomitant coronary bypass at the time. It already takes a complicated operation and makes it more complicated. So we will go PCI if possible in that route.
And just finally, could you comment on our healthcare delivery processes related to acute dissection? Are we doing a good job? What efforts are in place to improve timely delivery and improve outcomes?
Great question. So these patients come in from all over the state and all surrounding states. We are close to launching our Emory Aortic Hotline so that we can get the ERs to call this number. Right now they call the transfer center and they get a hold of maybe you guys or cardiac surgery or vascular surgery, and then we get them in. We have been working on a rapid transport to, and of our 3 hospitals, this hospital is the ideal, and it's pretty much agreed upon by the players at the hospital for the endovascular therapy for these patients. For the type A's, they can go to any of our 3 hospitals, but for the endovascular management of type B's, they should come here. And it's a challenge because we, as you guys all know, we never have beds at this hospital. Never. So we're playing, it becomes a very complex conversation with the transfer center, et cetera. And we're asking administration to try and give us some aortic reserve beds, which I don't know that will happen, but I will say that we have made strides. We've been able to rapidly transport patients instead of stopping in the ICU, which you guys know sometimes we'll have to park a dissection in the CCU, which no one likes, till the operating room staff gets here. We've made some strides in getting these patients rapid transfer to the OR, but there's still a lot of work to do. Having 3 hospitals does give us flexibility. I will often admit type Bs to other hospitals if necessary, if I can't get them in here. And I have done stents at the other 2 hospitals as well. So it's a work in progress is what I would say. And then as far as the medical management, I put all these patients on, I just take the Walmart $4 list of high blood pressure medications and start clicking them off. That's what they get, which I'm sure you guys do too. All right, great. Thanks, guys.
The preceding program is copyrighted by Emory University.